We're going to move on now and do appendicitis. Another one of my favorite topics. A kid I grew up with is a pediatric surgeon now at Boston Children's Hospital, Sean Rangel. And he published this article in a surgical journal called Effective Reduction in the Use of CT on Clinical Outcomes of Appendicitis. And this was a really cool article. And as much as we try to make the CT scanner look really inviting to kids, it's probably not the best place for a youngster with the radiation involved. They tend to have more radiosensitive tissue, and they have more years in their life to develop cancer. So I'm obviously biased towards ultrasound and using it for appendicitis. So I'm gonna try to present some data to you about appendicitis and see what we can come up with here. But this was my buddy's study. They did a huge study reviewing 35 different pediatric institutions over a 4-year period, and they just wanted to look for trends of CT use over the last 4 years at pediatric centers, and negative appendectomy rates, and complications like perforation, and return revisits to the ED. The results were fascinating. 52,000 children with appendicitis. This is a kid I sat next to in typing class in 7th grade, did this awesome study. Ultrasound increased 46% during the study period. CT decreased by 48%. Negative appy rates declined during the 4-year period from 4.7 down to 3.6, and the perforations didn't change. It was the same amount of perforations. So this is wonderful news that we should really be pushing, at least in pediatric patients, to reduce some of that radiation. So what you do in patients when you do an appendicitis study is you have them take their right leg and cross it as far as possible over their left leg. If you want to do some bowel intestinal ultrasound, because that kind of lines up the bowel a little bit better for doing the compression technique. When you cross their leg over like that, you're going to be pushing pretty hard to compress these air-filled loops, and that gives you a place to kind of push off from. And it's important to give them fentanyl. I give all these patients fentanyl before I do the study, okay? Because you're going to be pushing hard where it hurts, okay? And the idea is to, you can't really read that, but it says, disease states of the intestine will result in decreased peristalsis and less air-filled loops. So when you have the pathology, whether it's appendicitis, small bowel obstruction, diverticulitis, all this bowel ultrasound gets better when there's pathology, if that makes sense. All right. Now with appendicitis, you know, you got to get in the zen of this whole thing. I sit down and I just compress and compress and compress, and ever so often you get lucky, and then, you know, it'll like kind of tease you a little bit, wink at you, and then you're like, oh, and as soon as you saw it, it's gone, you know, and you freeze and you cine back and you're like, oh, there it is. And then, you know, you unfreeze and maybe you save that clip, and then you unfreeze and you go back and you're just doing this graded compression technique, mowing the lawn down there in that right lower quadrant, in the transverse plane, the sagittal plane, graded compression. I sit on a stool while I do this study. You know, normally when I'm doing a point-of-care ultrasound, you know, the other study I kind of spend a little time with sometimes is DVT. I might, you know, getting all the way down through that femoral canal. Maybe takes a couple extra minutes, you know. Here, on appendicitis, this is the one time I'm like, you know, hold my calls, I'm going in for an appy study. I probably spend 5, sometimes 6, 7 minutes doing the study. I really try to give it, especially in a kid, the best shot of, because I'm putting it all together. I'm looking for the appendix, but I'm also really doing like a super aggressive like abdominal exam with my hands. You know what I mean? So I can tell really how tender they are as I'm doing this, and all that's playing into my conformational bias, right? So, which is a good thing. So yeah, I sit down, I lower the bed, I actually lower the ultrasound machine down, so we're all like at the same level, and I sit, and I have the patient bend their knees, and I talk to them, I talk to the parent, I do the ultrasound on myself. If it's a kid, I'll do it to the parent. I try to get everybody kind of together here. I time the fentanyl with the ultrasound. That's important, because if you go to the computer, order fentanyl, nurse goes and pushes it, 45 minutes later, you go in the room, you're like, oh shit, the fentanyl wore off, right? So I tell the nurse, call them up, hey, listen, I'm going to go in there and do an ultrasound. Can you get the fentanyl? Can you wait to push the fentanyl till I'm like setting up the machine? And fentanyl, as you know, works immediately. They start scratching their nasolabial fold, you know it's taking effect. And the appendix should be 6 millimeters or less. And sometimes you'll see the cause of the appendicitis, which is a stone blocking the entrance of the appendix, the appendicolith. And you're looking for periappendiceal fat. I'm going to talk more about that, and the loss of that normal three-ring appearance of the bowel. So this is the technique. I'm compressing fat, muscle, appendix, psoas. Psoas? Hard to see. Yeah, psoas is over here. Some iliac vessel here. Psoas, iliac. Yeah, probes backwards here. That's okay. This is the loop, that loop coming along here of this appendix. This is the hypoechoic outer wall. And you can see this should be less than 6 millimeters, outer wall to outer wall here. And when I compress that appendix, it should easily compress. It should become ovoid and not round. If the appendix lacks an ovoid nature when you compress it and remains round and is more than 6 millimeters, that's appendicitis. And sometimes it's just the tip of the appendix that gets inflamed, okay? If you can have tip appendicitis, which is you kind of roll out here towards the tip and rotate into a transverse plane, get on that thing, try to compress it. But in order to make the diagnosis, it doesn't really matter what plane you're in. Longitudinal planes in general are pretty all over the body when you see organs that way. However, absolutely transverse plane, if that's how you get it, you get it. You get it any way you can, oblique, whatever you got to do, you get the diagnosis. Here's another example here. This is the psoas muscle, and it's the longitudinal axis now. We see those fibers stretching across. Here's abdominal wall. And what I'm seeing here is a normal-looking appendix that's kind of squirting out between my psoas and my abdominal wall. This is the technique, guys. You find that psoas, you just compress that muscle right down to it and try to squish that appendix between those two structures. Generally speaking, this is where you're going to find it. Psoas, abdominal wall, and we're seeing this appendix right along here. Okay? Here's another one here. What's that? What's that right there? That's the TI, that terminal ileum. Mid-peristalsis has this floral pattern to it, this really pretty looking, in that transverse view, it looks like a flower to me. That's how I know I'm right near the appendix. That is not the appendix, though. That's the terminal ileum. Okay, so when you find that, the TI, you know you're close. Maybe go a little more inferior. Here's another example here of positive appendicitis. Psoas muscles down here. Abdominal wall musculature is up here. There's that appendix right there. It's getting squished between these two muscles. And this one was like 9 millimeters. Outer wall to outer wall. Here's, let's see, what do we got here? We can't find the appendix on this view here, but this is the technique. This is, what do you guys think about this? This one's cool. This is the origin of the appendix coming off this way, very dilated over here. Here's that poop stone, that fecalith right here, blocking the entrance of the appendix and is the cause of this inflammatory condition. So we call a ring of fire. There's a still image showing hyperemic flow around an inflamed appendix. I was at AIUM last year and saw a radiologist, I believe he was from Brown, gave an amazing talk about appendicitis. I tell you, that's a wonderful conference. I learned so much. And he was all poo-pooing, no pun intended, the ring of fire sign. And I love the ring of fire sign. We see it also with ectopic pregnancies. I feel like I can really get my OBGYNs to, like really want to go to the operating room when I can convince them there's a lot of vascularity around that ectopic. Same here. I feel like I can really demonstrate the hyperemia here. This radiologist felt otherwise. So you can't, probably one of those things you don't really hang your hat on. Here's some examples of some appies that we found. Here's your TI right here, terminal ileum. Look at that, just medial to the terminal ileum. This little appendix probably went out of the plane and then came back across the screen here in a transverse view. With compression, psoas is down here, psoas, appendicitis, appendicitis. Here's a fecalith for you, a little ring of fire in the longitudinal plane. What do you think about this one here? This is periappendiceal fat. Do you see that? Periappendiceal fat. Periappendiceal fat is very important. When you see that, it's definitely acute appendicitis. And I've got a cool article to explain why that is. This is another appendix down here that looks very inflamed. Periappendiceal fat adjacent to it here. And we're fanning through it, this dilated, non-compressible round structure here that has periappendiceal fat around it. Good. Here's another case here. We're compressing lot of abdominal wall muscle here, very muscular individual here, six-pack abs kind of thing. And we're compressing here. And unfortunately for this guy, he's got this inflamed appendix here in that right lower quadrant. So this was a study done by some surgeons, radiologists in the UK, and recent, I don't know, maybe 2014, I think, and they were all negative about ultrasound and appendicitis. They're in a community hospital saying, you guys with ultrasound, we don't think it's as accurate. We only saw the appendix 45% of the time in our 3 sites. Our sensitivity, is more like a coin toss when you include these inconclusive ultrasounds. And this is the number of appendectomies they performed in the 3 centers here, and the age of their patients. In other words, it's not too many kids in the study. But as you'll see in the slide's off the bottom of the screen, but I just want to point out that the study, the center that doesn't have that many patients, it didn't have as many appendectomies, they didn't do as many ultrasounds, and they only found the appendix 21% of the time. A trend you see all the time, which is when you order more ultrasounds from radiology, your sonographers in radiology get better. They hate doing these studies, but they get better at it the more you order it. They start to get their mind around it a little bit. They explained their study in the sense that some of the sonographers are a little reluctant to make the call because they know that this is going to really impact the patient outcome. They're either going to get cut open, or maybe they're not going to get another study like a CT, and they're going to go home with appendicitis and perforate. So sonographers may be a little reluctant here in their studies, in their centers. It's often with the orders, they're whining about how busy they are. There's this Hawthorne effect where with the ultrasound, the published literature, like in studies that we're all doing right now, publishing our literature, we're all the experts, and so like I just told you, my technique where I might spend up to 10 minutes doing an ultrasound, that may not be consistent with the rest of the world because we're so obsessed with it. And so, but I think I'm obsessed with preventing a child from getting an unnecessary CT scan. That's where my obsession comes from. So that's, and maybe some medical legal concerns, lack of expertise. Some of the authors are here in the room today, both Mike and Pat here, looking at, they did a prospective study with 97 cases here, and they had a sensitivity of 67%, specificity high 98% here on those 97 cases they did. And so that's sort of some of the point-of-care literature. I did a study with some similar sensitivity reading 64% and a higher specificity. This is all the point-of-care sort of literature. If you tie us all together, our sensitivity is probably around 75%. But I'll tell you, when I did this study, I did my study back in 2008, my test characteristics now are going to be way better because I've gotten way better at it over the years. And so this was an interesting study. What are the factors that really influence how we do the study? What make us really, what are we looking for? What are the factors we're looking for on these ultrasounds? This is a study published by radiologists, and they looked at a 5-year review they reviewed all these ultrasounds for 5 years to see sort of what are the training of the personnel involved and what's their accuracy. Interestingly, they found 246 out of 1,000 cases where they could actually identify, not say appendicitis, but say that's the appendix. So pretty low rate of identification of the appendix. Like a quarter of the time, they're actually going to see it when they go to look for it. Pediatric sonographers are way better than non-pediatric sonographers. Again, that gets to the whole concept of how you talk to the kid, how you get them to let you do an ultrasound on them, and having a lot of patience and taking your time. Of course, the larger the BMI, the harder it becomes to find the appendix. And when they find the appendix, they don't do as many CT scans. This is some of that data. During the daytime, when the good people were there, they were able to find, they had some 66% sensitivity. Not as good. At night, it dropped down to 60. During the day it was 79%. During the night, it was only 61%. It's kind of interesting. Depends who's there. When this is the math on when they actually found the appendix. Well, then their sensitivity went through the roof to make an accurate diagnosis for appendicitis or not. 99% if you can actually find the dang thing. And so that's the deal. This is probably my favorite slide from that article, is the sense that as you go through the years from 2005 down to 2010, the the time in which you could find the appendix really went up, and the false negative rate went down because you could find the appendix once you got better at doing it. That's the whole concept here. They did a lot less CT scans during the period, and they found all kinds of other interesting pathology while they were searching for the appendix. Here's another one here, reevaluating the sonographic criteria for acute appendicitis in children. This was a retrospective analysis, but they looked at, what are we looking for on ultrasound when it comes to finding the actual ultrasound findings, on these, is there one finding that sticks out that really cinches the diagnosis for appendicitis? And it's this periappendiceal fat. That's really the one. If you see that one thing, you're done. There's all these other things like hyperemia with that ring of fire, appendicolith, whether you see that or not. Even the diameter and the non-compressibility it didn't correlate as well with true appendicitis in the pathology reports as this periappendiceal fat. So interesting. So this is some normal fat seen around this appendix. This is straight from their article, by the way. And this is it's this fuzzy periappendiceal fat seen around appendicitis there. And then the rings around the appendix normally is, in the bowel wall, you've got those 3 rings. The mucosal layer, submucosal layer, all that stuff. You start to lose your rings here, and then really when you have true appendicitis, this is a kind of there's only one ring. It just looks like an ectopic pregnancy, basically. It's look like a tubal ring. You get this one ring here with all this periappendiceal fat. That's how you do it. Yeah, they talked about appendicoliths, but again, they kept coming back to this periappendiceal fat. Here's a beautiful longitudinal view of an appendix here with this surrounding periappendiceal echogenic fat. Cool. So keep an eye out for that. Alvarado scores. Do you guys use this? I love these Alvarado scores. I think they're very helpful. This was appendicitis in children using Alvarado scores. They did a big retrospective study. They did a really good follow-up. They only all the kids went to surgery, or they all had clinical follow-up, and they did the Alvarado score. This is the score, just to remind you. You get a point for migration of pain to that right lower quadrant. You get a point for having ketones in the urine or having anorexia. If you're vomiting, you get a point. You get 2 points for right lower quadrant tenderness in the physical exam. You get a point for rebound tenderness. You get a point for fever greater than 37.3. You get 2 points for leukocytosis greater than 10K. And if you have neutrophilia more than 75%, you get 1 point. Interesting that the white blood cell count, as much as we make fun of it, it's still a real big factor in that Alvarado score. So here's the upshot for this study here. A positive appendicitis ultrasound with a positive Alvarado score, like everybody went to surgery and there's a very high p-value. If you had an inconclusive ultrasound, right, and a negative Alvarado score less than 5, inconclusive, can't find the appendix, Alvarado score less than 5, only one of these patients had appendicitis. Now, if you had an inconclusive ultrasound, but this kind of like mediocre Alvarado score, your negative predictive value went down to 89%. Still not bad, though, even with a lower Alvarado score. So I like these Alvarado scores. They're low. They really help me out when I can't find the appendix. So just clinically what I do in those situations, if I call a surgeon and say, hey, we did an ultrasound, we couldn't find the appendix. We got an ultrasound from radiology, couldn't find the appendix. The Alvarado score is 7, but I'm not convinced this kid has appendicitis. If I had that phone call to the surgeon, they're going to say, get a CT scan and call me back. So I got to be careful when I start to engage my consultant here. It depends a little bit on the surgeon. Some of them will just admit the patient and observe them for a day and see if this goes away. But if I'm not really feeling it and the family's really reliable, I'll actually send these patients home and have them come back in 8 to 12 hours for abdominal pain recheck in the ones I get a good vibe from that would actually come back. And that's most people. So, because I know as soon as I pick up the phone and call a surgeon, that almost invariably means a CT scan. And that may be the right thing to do, but I try to think hard before doing that. Here's an acute appendicitis seen here. This one is a centimeter. Here's another one here, marching along. Here's another one. I just have so many of these. This one's got some debris, probably a fecalith here, this hyperechoic material here, just to kind of lock it in your head what you're looking for. Another example here, fanning through this. By the way, these last few images are all courtesy of Matt Fields. He gave me some really cool, this is a big fat appendix here seen at the end of that clip there. You can see this enlarged appendix seen here as you fan all the way through. So it's important to to fan all the way through these guys here. Another example here from Matt Fields. This is the psoas muscle, and we can see this this thickened loop of bowel here, this very thickened loop of bowel, and I'm starting wondering, is this appendicitis, a very thickened loop of bowel? And I keep scanning, I see multiple loops of bowel with thickened walls here. Wait a minute, this is not the appendix, this is an appendicitis. What is this? This is terminal ileitis. And so you'll see some of that sometimes, which, some people will treat with antibiotics depending on the white count and the symptoms. Some people will watch it, but when you're down in that right lower quadrant, keep an eye out for that. Keep an eye out for intussusception, another finding that we're likely to see down there in the kids. So in summary, you're looking for that non-compressible 6 millimeter tubular structure in that right lower quadrant that gets sandwiched between the abdominal musculature and the psoas. Sometimes you see an appendicolith. You're really trying to light up some periappendiceal fat around that appy, and the more you do this, the better you and your sonographers are going to get.